For a number of years, we and others have used blinatumomab for our patients with Ph-positive ALL who have not achieved MRD negativity with approaches such as TKI plus steroid alone. And in order to study this in a more structured manner, and given the fact that we had seen good efficacy in series that we and others have published to date, we decided to initiate a phase 2 study. Now, this is an investigator-initiated study. It has just started up at MSK. There was a little bit of a delay due to the COVID pandemic, and we are hoping to open at another site shortly. Basically, this is a phase 2 study investigating TKI therapy followed by blinatumomab with some similarities to the D-ALBA study, but some important differences. First of all, this study will allow investigators and patients to change TKI therapy as indicated based on intolerance to dasatinib or other factors at the discretion of the investigator. And it will also introduce blinatumomab as early as 6 weeks into treatment. Now, as we saw in the D-ALBA study, and as we ourselves have seen, resistance to TKI plus steroid can emerge in a handful of patients as soon as 6 weeks into treatment. And in fact, in the D-ALBA study, in the range around 9 weeks into treatment is when they started to see some of these resistant clones emerge. And in order to try to suppress that, we decided to introduce the CD19 targeted therapy as early as 6 weeks in patients who had achieved a morphologic complete response. The other difference of note is that we've built in a blinatumomab maintenance program. You know, Ph-positive ALL affects older adults predominantly. And for many of those patients, transplant may not be a great option, or they may decline transplant. And as such, we decided to investigate a program of blinatumomab maintenance for patients who achieve a complete molecular response within 3 cycles of consolidation, but are not proceeding immediately to transplant. And those patients can receive 1 month on, 1 month off of blinatumomab for up to 4 additional cycles. And of course, we'll be interested to see how that works as well. Now, this is just a small study. This is just a 17-patient study that has a Simon's 2-stage minimax design where we'll enroll 10 patients, and if we see 3 or more complete molecular responses, we'll enroll up to 17. We are hoping that that'll actually provide some prospective data from within the United States as opposed to just within Europe, and will also demonstrate some preliminary data regarding the safety and feasibility of blinatumomab consolidation in patients who are not proceeding directly to an allograft. It's going to be a while before we see the results of the ECOG 9181 study, which I had commented, which will be the forthcoming TKI plus steroid versus TKI plus chemo comparison. And we're hoping that our study will provide some information to the community while we're awaiting the larger randomized trial, and in some ways will allow us to explore some factors that were not investigated prospectively in the D-ALBA study. So this is a trials in progress, you know, and so we are not presenting results at this meeting. The goal of the poster was to basically show the investigators in the New York area that if they have patients with newly diagnosed Ph-positive ALL that are looking for a chemo-free approach, that we have this study open and available, and that we're actively enrolling. But you know, we are not sharing results at this meeting. This is essentially just a trials in progress to let folks know the concept and the ongoing study. Yeah, that's a great question. I think that the results from this study will certainly help to solidify that across multiple centers and multiple approaches, whether TKI plus blinatumomab consolidation is associated with the rates of deep and durable response that have been suggested by this small series to date, and may firmly establish this as an alternative approach to TKI plus chemo consolidation, which has become more standard of care. And then, of course, I think that as the data mature from this study, and from others, we'll have a better sense of what the natural history is for patients who do well with an approach like this, but who do not proceed to transplant. And I think that that'll be more important information as well as we help our patients navigate decisions, such as whether or not to proceed to transplant in first remission. And we hope that that will, again, be a significant help to physicians in this space who are having these conversations with their patients.